Some are organ-centered, like the Glasgow Coma Score, or the Ranson score for pancreatitis, or the Child score for liver failure. But of course, we have a general score that we largely use, which is the Apache score or the SAPS score, and then the SOFA score. The question we should raise is, what is the purpose of these scores? How will they really influence patient management? Not many play a role in individual decisions. Well, the Glasgow Coma Score could, to decide to insert a intracranial pressure monitoring, for instance. But many scores are used for description of patient populations, for epidemiology studies, or for clinical studies to compare two groups, for instance, maybe for quality control. But the Glasgow Coma Score, the Child score, may be used for a given individual, okay. But severity scores don't help. I never need an Apache 2 score or 3 score at the bedside. Likewise, I never calculate a SOFA score at the bedside. It is meaningless. It does not help me. Actually, when I enter the room here in our department, when I see so many pieces of equipment, I think the patient must be critically ill. And indeed, on this basis, the TIS score was developed years ago. But it's more useful to estimate the amount of work for nurses than for really evaluating the patient's prognosis. Now, let me emphasize that any abnormality in medicine is associated with a worse outcome. If we think about it, blood pressure, heart rate, albumin, bicarbonate, procalcitonin, whatever. Whenever there is an abnormality, there is a worse outcome. Look at this. Very nice relationship between a particular variable and mortality. It's bilirubin. Bilirubin has a very strong prognostic value. Okay, it doesn't mean there is something specific we can do about it. Sometimes yes, sometimes no. But if we think about it, the severity scores, like the Apache score, was based on abnormalities of very simple variables, and usually they can go both ways. Heart rate, when it's very low, that's quite bad. When it's fast, it's quite bad. Blood pressure, likewise. The serum potassium, likewise. Some values go only in one direction. The creatinine in one direction, the Glasgow Coma Score in the other direction. But it's by putting these elements together that the Apache score calculated during the first 24 hours in the ICU can estimate the risks of death, the hospital mortality, the risk of death at time of hospital discharge, which is a valuable reference point. Now, how would you describe organ dysfunction failure? That was our starting point. How could we best describe organ dysfunction? And if we think about it, there will be basically 6 organs whose function can be easily evaluated: respiratory, circulatory, renal, neurological, hepatic, hematological. And the problems with the early organ dysfunction scores is that they were dichotomous. Is organ failure present or absent? That's not good. Or included diagnosis. It's a myocardial infarction. That's a cardiovascular problem. No, 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 no. That's not the assessment of organ function. Of course, we don't need complex measurements. Of course, they could be multiple events like arrhythmias. That's not too good. And in the past, there was no real reference to time. So, in the development of the SOFA score, we had 2 important principles. One organ function is a continuum. So it's not an all or none phenomenon. How to define renal failure? Is it a creatinine of 2.5, 3, 4.5, 5? Well, it's a continuous variable, isn't it? And the organ dysfunction can change over time. It's a dynamic phenomenon. A patient may have a normal creatinine today and an abnormal creatinine tomorrow or the day after, and then it can go down again. So the time is of fundamental importance. We could have patients in whom one organ is improving, in this case, the respiratory function, when other organs are getting worse. So we need to look at subscores. We need to look at the function of each organ taken individually. And obviously, the ideal variable should be objective, simply easily available but reliable, obtained routinely and regularly in every institution around the globe, specific for the function of the organ, should be continuous, independent of the type of patients, and if possible, independent of the therapeutic intervention. But that's difficult. That's difficult. If we think about it, if we go back to the 6 organ dysfunctions, yeah, what we do to the patient may influence the variable. As an example, we have a patient with quite severe respiratory failure here, with a PF ratio of 200 millimeters of mercury. It's going to 250, 260. That's better. Well, I increased the PEEP and I put the patient in prone position. So are we sure this is an improvement, or is it due to what we have done to the patient? Or this is the other example for cardiovascular dysfunction. Patient has a blood pressure of 100 over 60. What do you think? Is it circulatory failure or not? Well, tell me more about the support. If the patient is off vasopressors, that's not bad. If the patient is on high doses of noradrenaline, that's not too good. So we cannot really avoid introducing some therapeutic elements in this. Okay, so we are not trying to predict outcome. That's not the point with SOFA-score. That's what we do with Apache. The aim is to predict the risk of death. The focus here is on morbidity, not mortality. It should be simple, easily calculated, individualizing each organ, and obtained serially, why not daily? So you see, people confuse sometimes. They say, oh, all these scores, the Apache, the SOFA. No, it's different. I love Apache scores, but for a different purpose than I love SOFA scores. SOFA scores will tell us more about the type of organ dysfunction or types of organ dysfunction over time. The Apache score gives me one global number at the beginning of the ICU stay. So the session, I think, is entitled Sepsis. The SOFA score initially was called the Sepsis-Related Organ Failure Score, Assessment Score. But we quickly changed for sequential because it has nothing specific for the septic patient, nothing. So it is the sequential organ failure assessment score, and you know the score, 0, 1, 2, 3, 4, for the 6 organs which are taken into consideration. Now, I say the SOFA score aims at describing organ dysfunction, but still, many people loved to evaluate the prognostic capability of the score. It's true that the more severe the organ dysfunction, the higher the risk of mortality, of course. But if you wanted to predict mortality, you would add lactate, you would add albumin, you would add a diagnosis of cirrhosis. That's what we do in the Apache score, but not in the SOFA score. No, 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 no. The aim is not predict mortality. But how do you validate it? We need some form of validation. So at the end, yeah, we still related to mortality. And that's what we done initially in 1996 in the European North American database, and we could show that indeed the score that we developed around the table, that's how we did, but it works quite well in practice. It has a nice relation with mortality in this database. Oh, you need to do it prospectively. Okay. So 2 years later, in 40 ICUs, we have done the same. It's interesting, if you look at survivors and non-survivors every day in the ICU, they are on parallel lines if you follow a patient population. That's because the number of patients represented by the yellow line is going down. Some patients leave the ICU, some other patients die. And so among those who stay there, every day the non-survivors have a higher score than the survivors. Okay. And then we did the SOAP study in Europe, a large study, again validating the score quite well, with this nice relationship between the number of patients and the number of organ dysfunctions. Of course, many patients have no failure of an organ, even though they are in the ICU. And the larger the number of organs failing, the smaller the number of patients, but at the same time, of course, the higher the mortality. And so we can see here that the mortality of 50% is associated with a score of about 13. And this has been shown in other studies I will show you in one moment. But the important observation, I alluded to that, but now I'm going into data, is that the changes in time are really very important. Regardless of the initial value of the SOFA score, if it improves after 24 hours, mortality is hardly more than 20%. If it worsens, more than twice that mortality rate. And this is true for all subscores. The dynamic is very important. For the cardiovascular status, coming in with high dose of vasopressor agents, of course, has a bad prognosis. But on day one, it's actually a more accurate prognosis. Those patients who were on vasopressors on the first day, if they are weaned from vasopressors, do not have such a bad outcome. But if patients were not on vasopressors on admission, if now on the first day they are on high dose of vasopressors, the prognosis is much, much worse. The same for the renal function. You have here the creatinine levels at the left panel. Okay, of course, the higher the creatinine, the higher the mortality rate. But at the right-hand side, you have the changes in creatinine, and the separation is more significant. So the changes in creatinine are more important than the absolute value. Okay, so let's move on. What we have shown many years ago in the JAMA here is that when the SOFA score goes down over the first 48 hours in the ICU, usually the prognosis is not that bad. So again, let's look at the changes over time. And with the large ICON study for the World Federation of Critical Care Medicine, 10,000 patients in 730 ICUs, we could show again the nice pattern of organ dysfunction with the initial SOFA score there. You have the number of patients represented by the blue line, and this is the delta SOFA. And again, we could see that the changes over the first 48 hours is really very, very important. Other people have shown the same. SOFA score of about 13 associated with a 50% risk of mortality, but the aim is not really to predict mortality, but if you want some form of validation, that's what we can come up with. So far, so good. So, is it time for an update? Actually, you could say, yeah, it's an old score. Many things have changed. What has really changed? We no longer use dopamine. Okay, but no, dopamine is there. Okay, if no patient is treated with dopamine, that's fine. Who cares? Oh, but now we use vasopressin. Okay, do you know when to use it? I don't think I will speak about it at this meeting, but now we have evidence from our group and other groups that the early use of vasopressin may be preferable to the late use as a secondary vasopressor agent when the situation is pretty bad. So, how do you put it in the score? Difficult. So, there are two ways to update a score if we want to update it. One is to change the variables, remove dopamine, add vasopressin, if you like, add lactate, or to change the range of the subscores, 0, 1, 2, 3, 4. So, remembering the list of characteristics of the metrics used, continuous, objective, simple, obtained routinely, specific for the function, if possible, independent of the type of patient, then how could we change it? SpO2 versus PaO2 so that we don't need to take arterial blood gases? Well, yeah, it's an approximation, but okay, we could introduce that. Hypercapnic respiratory failure, that's very difficult because we need to introduce the pH. There may be hypercapnia associated with metabolic alkalosis. The PEEP level, as I said, is not considered, but that would add complexity. High flow nasal oxygen, probably it has a minor impact on the evaluation of organ dysfunction. Of course, ECMO will lead to a score of 4. Of course, that's a definitive failure. So the proposed changes are relatively minor if they are even present. For the cardiovascular system, no, we don't want to introduce the lactate level. No, the changes are too slow. Patient may be out of shock with a lactate level, which is still a bit increased, so that would not work. Dopamine is abundant, other pressure agents are not considered. Of course, VA ECMO would lead to a score of 4. So at the end, not much to change. Renal system, we don't use these new renal biomarkers. And of course, renal replacement therapy will result in complete failure with a score of 4. So we don't know really what to change. The hematologic system, well, maybe we could introduce some other coagulation tests, but they should be obtained routinely in every institution. And of course, PTA-PTT could reflect liver dysfunction and or anticoagulant therapy. Hemoglobin, maybe, okay, but transfusions must be taken into account. So it's not clear what we need to change there. And for the neurological system, we have not found anything better than the Glasgow Coma Score. Of course, sedation is a problem. Hopefully, we sedate less and less in the ICUs. So it's less and less a problem. So we need to insist on the recording of the assumed Glasgow Coma Score. If the data are taken automatically from the bedside system, this may still be somewhat problematic. And for the hepatic system, bilirubin is really not very good. But liver enzymes are not very good either because they can be released by muscles, even the heart. So at the end, well, could we actually consider other organs? The GI system, we have tried over the years, it doesn't work because what is not tolerated nutritional support? How much vomiting, how much diarrhea? Intra-abdominal hypertension is still relatively rare. The endocrine system, very difficult to quantitate, and the immune system, likewise. We do not measure HLA-DR routinely anywhere. So at the end, this is the summary slide of the possible changes in SOFA2, in SOFA score. And we could change the existing variables. We could say, well, if we change a little bit here, a little bit there, we may improve the range of values. But I showed you that after all, as it is, it works relatively well. So at the end, we went for a potential development of a SOFA2 score. And as you can see on the paper, we are 62 authors. If you want to be co-author, please join. But do it fast because the paper will be submitted actually as we speak. But I'm not allowed to show you what we have done, but the message is that the changes are really minimal. Even though large databases were used to rethink the ranges for each subscore and for the possible addition of other variables, at the end, this SOFA2 score resembles very much the SOFA score that I spoke about. Now, why not? I'm not against it, and we have had updates of the Apache score, the MPM score, the SAP score, why not the SOFA score? But I don't think that that will really change our world. I still use the Apache 2 score very routinely, even though it may not be so good. At the end, a score is always an approximation. It's never something which is very, very precise. So with this, thank you very much.
Thank you very much for this interesting lecture. We have one question. If anyone has any question. Yeah, do we have the mic? We can send it to the lady.
Thank you so much, Doctor, for this really great presentation. It would be very interesting to go back to those scores and look how they are assessing our patients. So thinking from surviving sepsis guideline and the changes of the guidelines and how using those scores may affect our patients' categorization or looking into their septic shock diagnosis, how do you think SOFA score 2 would affect the definition of septic shock patients? Will that affect our definition at all or not? And how strong do you think the new definition of sepsis and septic shock in defining those patients?
Yeah. Now, it's not the surviving sepsis campaign guidelines that referred so much to the SOFA score. It's more our consensus when we developed what people call the sepsis 3 criteria. I don't like it because sepsis has always been sepsis and will always be sepsis. But in terms of criteria, that's right. When we wrote this paper, we thought we should have some objective measurements to include patients with sepsis in our trials or in our epidemiological studies. So that's how we needed a relatively objective score to do that. And so we selected the SOFA score with a change by 2 units to be compatible with sepsis. And so, of course, I supported this like the others. It was an easily achieved consensus, but it as I said, it will not change my practice at the bedside. I don't need a SOFA score at the bedside. If someone calls and says, you know, I have a septic patient here, I would like the patient to be transferred to the ICU, I will never say, are you sure the SOFA score went up by 2 points? People on the floor may not even know how to calculate the SOFA score, and I don't know it by heart. I need to look at the score, even though I have worked on it for decades now. Again, this is very important for clinical trials or for epidemiological studies, yes, but not for patient management. I don't care about the SOFA score at the bedside. So really, we should not ask too much about it because it's not necessary. If you tell me that your patient is septic, I can trust that this patient is getting worse, and I will admit the patient in our department.
Thank you so much.
Thank you very much, Professor Vincent. We'll move quickly because we are out of time. Our next speaker is Professor Yahya Shihabi. He is coming all the way from Australia, Monash University, New South Wales. He will be giving us a presentation about the duration of antibiotic prescription to bloodstream infections in critically ill patients. Professor Yahya?
Good afternoon, ladies and gentlemen. Thank you so much for the introduction. It's always a challenge to speak after John Louis with his, energy and drive. So at least he's waking you up for the afternoon, and I'm hoping to keep you awake in this late session today. Let me make sure that I do the right thing because I saw good. So. I just wanted to congratulate the organizing committee and especially Dr. Abdurrahman Al-Faris for a really fantastic conference. It is my first time to Kuwait, and I'm enjoying the hospitality. And it's really great to see that there is a connect between the Pan-Arab critical care community and also the World Federation community. And I think that memorandum of understanding that was signed today is really a fantastic step forward. One thing I wanted to tell you, last night at the faculty dinner, I had an Ali, and I'm a big fan of Ali. So if there is an Ali at the dinner tonight, make sure you have at least 2 bites from that. I have no financial interest to declare, and I just wanted to declare that I was the Australian ICU lead for the balanced trial investigating the antibiotic duration in bacteremia, and that was funded by an Australian government grant. I think just listening to John Louis just reminded us how bad bloodstream infections are. And it's very common, and in countries like our region here, they're probably underestimated because we don't have probably enough data and reporting to report what actually happens. But on average, it's about 200 per 100,000 population, which is quite common. And the mortality and morbidity from sepsis is very high, and it's usually driven by factors such as what's the pathogen, between a gram-negative or a gram-positive infection, and also patient factors, whether they're immune-compromised, elderly, they're young people, and then the timing of the diagnosis. Sometimes people come to the emergency department, they get sent home for some reason, they come back and they miss the diagnosis, and they usually have fatal consequences. The timing of appropriate antibiotic is absolutely critical, and that's when antibiotics is actually given on time and with an appropriate dose. For some reason, the slides is cutting the bottom end of my slide. I don't know why, and the font are all changed, but I'll try and If there's something missing, I'll tell you about that. So with the increase in the global infection of sepsis and how common it is in the world, there is an increasing rise in the global use of antibiotics. And I think this graph here just demonstrates how much antibiotics is expected in 10 years from now, and the cost of that. It's really not just billions, it's trillions of dollars. So it's a huge market in terms of antibiotic that are used around the world. And if you look at Australia, we always think that we do things very well. Perhaps maybe there is one area that we need to improve on. And this is kind of like an inside look, or the look in the mirror about how do we use antibiotics in a country like Australia. This publication from 2023 showed that there is a substantial use of antimicrobials in Australia when compared with countries like European countries and also compared with Canada. And there is also a significant variation between the states and territories themselves. So you'll find that people on Darwin, for example, they will use significantly more antibiotics than people in Tasmania, for example. And the one thing that's really important is that over time, there has not been any improvement in the antibiotic prescription in terms of appropriateness of a drug prescribing, whether it's duration or the choice of the antibiotics used. And this is data collected by the Australian Medical Association, which looked at the resistance impact, and it was mentioned this morning in one of the lectures this morning. And it's interesting to see that resistance, whether it's resistance from the pathogen that's already been treated or from a bystander pathogen, is actually causing significant death. And you look at the top 10 leading causes of death, drug resistance or antibiotic resistance is kind of like the third cause of increased death in these patients. So knowing that sepsis is there with all the bad things that it does, knowing that we have a significant increase in the amount of antibiotics that we use, knowing that we are not as good as we think in the way we use antibiotics, we do need to have a different way of approaching it. And I think when we look at the duration of antibiotic as a question, balancing that duration is really essential. And it's essential for two main reasons, because if you use a short duration, then you risk of a clinical failure that you have not treated and eradicated the infection appropriately. And that clinical failure will lead to a relapse, and then you're back to where you started, and more likely you're back with an organism that is already resistant to the antibiotics that you've already received. So you're kind of like going into a vicious circle. So it's really important that the timing and the appropriateness and the duration that's given is enough to prevent the clinical failure and prevent the relapse from occurring in those patients who are treated. However, treating for too long is also associated with significant problems, because you will develop resistance in bystander flora. You may develop Clostridium difficile, which we're seeing a lot of it by all the broad-spectrum antibiotics that's been used, and you are exposed to a lot more adverse events. And also, of course, there's a cost associated with that. So that balance is really quite critical in terms of the duration of antibiotics that you want to use. So traditionally, we have used multiple strategies to reduce the duration of antibiotics. And I think one that probably used across the world in most hospitals is the antimicrobial stewardship. This is one of the probably the daunting exercises in ICU ward rounds, where you have a bunch of doctors. They always come in like with their entourage, 3 or 4 of them. They're all in black suits and sometimes nicely dressed, and they can be quite intimidating sometimes. And really, they have the same data that you have, but they have the right and the privilege to give you and tell you what to do. So they follow the model, which is quite a nice thing, the 3 Ds that they follow. You know, make sure you're giving the right drug based on the condition and the antimicrobial surveillance. Make sure you get the right dose, whether there's a kidney dysfunction or there's a hepatic dysfunction, so the right dose is given. And then de-escalate once you know what the organism you're treating is. All these are really excellent principles, and they are the principles of the antimicrobial stewardship, which I think is important in terms of reducing the exposure to antibiotics. And more importantly, it looks at providing the right duration. I think that's the right duration continue to remain probably the one aspect that we debate with our friends in infectious diseases and microbiology when they come to do their AMS rounds in RCU. We heard a lot about the SOFA score from John Louis, and perhaps a lot of us say, well, their fever disappeared, they're off vasopressors, they look fantastic, so why don't we stop the antibiotics? And I think probably that is not yet there. I think if we just follow improving patient, we probably need to go beyond that clinical eye that the patient is improved, they're not febrile anymore, their white cells come down, so let's just stop the antibiotics. So I don't think we are there yet with a strategy of that nature. Then we come to the biomarkers. I think biomarkers probably, we have seen a lot of work on biomarkers in the last few years, and you look at the graph where biomarkers like interleukin-6 and 10 and TNF-alpha, procalcitonin, and C-reactive protein, they come up and disappear in different times after an enterotoxemic challenge. You can see from this graph here that IL-6 and TNF-alpha, they come quite early. They're not really that useful when it comes to determining antibiotic duration. Probably something like procalcitonin, which peaks about 6 to 12 hours, probably is the ideal in terms of deciding which biomarker to target. CRP seems to be a bit non-specific, and it takes much longer to actually peak. And I think when we look at the studies that were done on biomarkers, they all have different things, and I think that's the problem with all these studies, that the cutoff is different from study to study, so therefore we have not come to an optimal cutoff level, for example, for procalcitonin or for CRP. Then the compliance in the trials of procalcitonin is also a bit of a problem. Some of these trials had a compliance of like 55%, some of them like had 60%. So you need a high compliance to really test those antimicrobials, to test those biomarker impact on the duration of antimicrobials. And then within these trials, the standard of care are different. So whether the standard of care include antimicrobial stewardship, whether it allow clinicians to overrule the procalcitonin algorithm that's been given to them, also is different. So there's still a fair bit of very important differences between the studies that looked at the biomarkers, especially procalcitonin. And there's been a few studies that were published on the procalcitonin, and also all these studies showed positive results, but they also differed in terms of patient, the patient they used, the population, the algorithms, the cutoff value, and also the compliance in within that. This is one of the studies that we've done in 2014. We done 400 patients where they were multi-center in Australia, and they were divided between those who were on a procalcitonin guided algorithm and those who were on standard care, and the standard care included antimicrobial stewardship. You can see here that if you look at all patients together, procalcitonin levels did not differ, but it declined kind of like in parallel over time. While if you look at if they have negative culture or positive culture, you can see that those who have positive culture had consistently higher procalcitonin than with negative cultures, and the decline was parallel. Where the difference was is if you look at those who were alive and dead, you can see that those patients who lived actually had a more rapid decline in procalcitonin than those who died. So a rapid decline in procalcitonin in those septic patients tells you that you are on the right track, you give them the right antibiotic, the right dose, and you can continue. More recently, just about a couple of months ago, the ADAPT trial from the United Kingdom was published in JAMA. And that was done in 41 ICUs in the United Kingdom, more than 2,700 patients divided into 3 groups. They looked at a group that received standard care, a group that received procalcitonin-guided therapy, and a group that received CRP-guided therapy. And the results of the primary outcome was for efficacy, duration of antibiotics, and for safety, 90-day mortality. What this trial population was, which is important to show that, to compare with the trials of similar nature, is that the population are primarily respiratory and intra-abdominal infection. It's important to remember that that's what was probably the same as in many of the other sepsis studies. And it showed clearly that the procalcitonin-guided algorithm was far better than CRP and far better than standard care. Standard care did the worst, where their antibiotic usage was significantly higher, but the mortality across the 3 groups was non-significantly different, but edged on the lower end with the procalcitonin. So this study, probably funded by the NIH in the UK, showed fairly clearly that a procalcitonin algorithm does reduce antibiotic duration and exposure without a difference in mortality. So with all that in mind, then can we follow a time-based strategy? Can we just say, well, why don't we give it for 5 days? Why don't we give it for 7 days? Why don't we give it for 10 days? Why don't we give it for 14 days? But where is the time? What time do we choose? And I think that's what the studies that I'm going to show you looked at. And this time-based strategy really depends on what organism you're dealing with. Are they gram-positive? Are they gram-negative? Are they in the blood? Are they in the bones? Are they in the heart? The site of infection is also very important. And there are also important patient factors, whether patients most patients, for example, who are immune compromised have been excluded from many studies. A lot of cancer patients or oncology patients have also been excluded from all these major studies. So I'm going to talk to you about the BALANCE trial, which is looked at the difference between a 7-day antibiotics and a 14-day antibiotic. The trial was conducted in multiple countries, and before the trial, there was a survey, national surveys, both in Australia, New Zealand, Canada, and other countries, that showed that at the time of these surveys, people were still using at least 9 to 15 days of antibiotics, with a median that sits about 11 to 14 in most places. So the people are still using 10 to 14 days of antibiotics in these surveys. So it was important to do this trial. This trial was funded by the Australian National Health and Medical Research Council, by the Canadian Health and Research Council, and other funding bodies. And the trial was led by Nick Denneman and Rob Fowler from Canada. We're in Australia, we love to do trials with the Canadians. They're quite a great group to do trials with. We're kind of doing 3 other trials with them. This is the participating sites in the trial, which is a lot of them all over the world. And the trial was published in New England Journal of Medicine recently. So the research question was, is 7 days antibiotic therapy non-inferior to 14 days of antibiotic therapy in its impact on 90-day mortality in hospitalized patients with bloodstream infection? So these patients, all of them had positive blood cultures, and that's very important to remember. The inclusion criteria, very simple. You need to be in hospital and you need to have a blood culture positive. And there was few exclusions which are important for safety, and the patient that were likely to require much longer than 14 days antibiotics, like endocarditis and other infections. The primary outcome was 90-day mortality, and there was a bunch of secondary outcomes as well, including antibiotic-free days and also incidence of Clostridium difficile and others. This statistical plan was a non-inferiority margin of 4%, and this morning we were talking about non-inferiority margin of 10% in the, when they compared the high-flow oxygen to non-invasive ventilation. And I agree that 10% is very high. I think 4% non-inferiority margin is probably a good margin to go for. And there was also a subgroup analysis where they looked at whether it's, look at the intention to treat or per protocol, and then they looked at patients who were in the wards or patients who were in the RCU. So this is important to remember this, as I said, to know what population has been tested. You can see that in the balanced trial, we use patients who are in RCU as well as patients who are in the wards. So they were a combination of ward patients and also RCU patients. And if you look at their physiological parameters, you can see that about 1 in 5 was ventilated because half of these patients were actually on the wards. And then 5% of them got dialyzed, and about 1/3 received vasopressors. So you could say that this group of patients are not really the sickest of patients that you would see in RCU, but they all had a positive blood culture. And the infection characteristic is also very important. Remember how I showed you the infection characteristics of the ADAPT trial, for example? The source of infection here is quite different. So you can see here that the majority of infections here are in the urinary tract and also in the abdomen and the biliary system. Most of the infections were, which is not what in the ADAPT, which was primarily respiratory and abdominal. You can see here that the primary outcome also showed fairly non-inferiority between the 7 days and the 14 days. So they're both pretty much equal in terms of mortality. So the non-inferiority margin were met between 7 days and 14 days. Secondary outcome, important that the antibiotic-free day was significantly more, as you would expected, in the group that received the 7 days, and significantly longer in the 14-day arm, and that resulted probably in a reduced hospital length of stay and also a reduced hospital-free day at day 28. The predefined subgroups showed that pretty much all subgroups showed the similar non-inferiority margin, and there was no difference whether you were in the ward or in RCU. Whether you're in both the groups, there was a non-inferiority between the two. So the conclusion from this trial is that 7-day antibiotic treatment should be the general strategy, and I emphasize general strategy for patients for bloodstream infection, as it is non-inferior outcomes and without a difference in mortality. More recently, there's a meta-analysis done on gram-negative infections. And again, that also showed that if you have a gram-negative bacteremia or infection, also 7 days of antibiotics is as good as 14 days of antibiotics. But remember, the qualifier in the interpretation that these patients were hemodynamically stable, afebrile for at least 48 hours before discontinuation. So
Dr.
do we have a preferred strategy?
Dr.
Yeah. So the preferred strategy seemed to be a combination of the three that I described: antimicrobials, biomarkers, and like the procalcitonin. Time-based is now proven to be a 7-day, but I think always individualize your treatment for those patients. And I think we're probably going to be looking at more of an AI integrated strategy to put all to that together to improve our prescribing for antibiotics. Thank you so much. Apologies for the delay.
No, that's okay. Thank you very much, Professor Yahya, for this interesting presentation. For the sake of time, we have time for only one question. If anyone is having a burning question to Dr. Yahya. Okay, we have a question here. If somebody can bring the mic.
Times or
48, 72 hours.
Yeah. Look, in my practice, I do it daily. In the studies we've done, we've also done it daily. And there's now a kit that gives you a point of care, quantitative procalcitonin, which can also be done like an ED or an RCU. I think, going forward, procalcitonin will become part of a routine management of septic patients and guidance for antibiotic treatment.
And you're looking for the trend rather than for becoming normal.
Correct. That's why it's not a single, one day you do it. I think you look at the serial measurements and you look at the trend in the change in the procalcitonin levels.
So thank you very much. It's now to invite our next speaker. It's my pleasure to introduce our next speaker, Professor Theodore. So, it's difficult, isn't it? Okay. Okay, please, the floor is yours, please. Your wife.
To see what the formatting looks like. Hi, I'm Jack Iwashina. I'm at Hopkins. I am honored to join you. I will add my thanks for your hospitality as well as your commitment, because it's 5 o'clock and you're still here, and that's remarkable, because I don't give a good enough talk for that to warrant that. So let's see what we can do. So I have no disclosures. Those are not my slides. That was the last speaker. That's the previous one. I am that one, yes. All right. Awesome. Here we go. I have no disclosures. So here's what we're going to do today. In the next somewhat less than 20 minutes, hopefully, I'm going to do sort of 5 stylized facts about sepsis survivorship to recount about 2 decades worth of work. Then I'm going to tell you sort of a simplified model that involves some graphics for how I think about these things now. We'll see if the graphics work, because that'll be exciting. And then I'm going to talk about some very pragmatic strategies of, since most of us are intensivists, not running a post-ICU clinic, what do I need to think about in my hospital when I'm on service in order to try to improve sepsis survivorship, right? So first component is when we talk about the problems patients have after sepsis, we have to remember that we all do critical care because we're really good at it and it's good for patients. While there are substantial problems after sepsis for a lot of our patients, most of our patients thrive. And it's really important not to get into negatives of that. At the same time, we used to teach that everybody did great, and it's not really everybody. So Gordon Bernard, who's a titan in the field, was asked in 2004, is there a residue in sepsis survivors? And in 2004, which is not that long ago for some of us, for some of you it was a long time, for some of us it was recent, he said, no, everybody gets better. And that's just not true. Hallie Prescott in particular has a decade of work showing that there's substantial post-sepsis mortality, This is where up to 1 in 3 sepsis survivors is going to die in the 1 to 2 years afterwards, and about half of that is probably attributable to their sepsis, not the underlying risk factors that led them to develop sepsis in the first place. So how do we think about this? In 2015, I drew this graph. It was pretty. It had lots of arrows. I think it actually was more pretty than useful. So here's how I think about these things today. So the first few slides we blow through, right? Oh. That infection causes dysregulated inflammation, which causes organ dysfunction. That's sepsis 3, as Dr. Vincent taught us. This is how we know. So how does this get to problems? Canonically, we think about sorry, my slides are now advancing on their own. If there's any way to stop that, that'd be awesome. We think of the classic triad of the post-intensive care syndrome or the post-sepsis syndrome: weakness, cognitive impairment, and psychological problems. One of the questions has always been, to what extent is that the result of the organ dysfunction itself, or is it actually also that organ dysfunction necessitates life-saving care? And our life-saving care has limitations. Some of those are the unavoidable side effects. The things we do are never going to be perfect. But the other problem is that then they bring them into the system. And inevitably, there are system lapses in human systems, not just from our life-saving care, but really all the other things we do. Sorry, this is exciting as I get to duel the computer. All the other things we do, some of which are just frankly iatrogenic. Much of the last 2 decades have been spent trying to understand what are the things we do that aren't life-saving, but are things we do that are actually harmful. Those that all together, the organ dysfunction, the unavoidable side effects, the preventable system lapses, and the iatrogenesis combine to form PICS. Those combine then with socially imposed barriers to cause a degree of social role dislocation, caregiver burden, recurrent healthcare needs, all of which in the context of ongoing system failures, often because we're just not that good after we get people out of the ICU in meeting their needs, lead them to come back, often with recurrent sepsis, such that we know that sepsis and heart failure are the leading causes of readmissions afterwards. We also know, increasingly, that good care can help. We know that patients who get sort of a relatively simple set of bundle involving de-escalation, some other components, are appreciably less likely to die. This is Stephanie Parks-Taylor's work. She's got a randomized controlled trial that's showing nurse-delivered support to this could help dramatically. But in the end, a lot of our care is focused on death preventing, and that's good. Not having people die is good. But what also would recovery-focused critical care look like? I think the first thing it's going to suggest is that we have to remember that we've neglected some pieces of this. I think one of the things COVID reminded us is how much the burdens of severe viral infection and other infections actually cause direct toxicities, and that the PICS literature has neglected this. Long COVID, I think, really emphasizes these direct effects, but also we don't have a good drug to fix them. There's not much we can do in the ICU with that. Instead, we have a very ineffective slide. What I'd like to propose we focus on is these middle parts. What are the parts where our life-saving care and our other care leads to system lapses and iatrogenesis that we can potentially fix in order to do things different? In particular, what I want to propose to you is that we should think about a final golden hour. That there's an hour at the end of the ICU that is potentially exactly as important as that hour at the beginning of the ICU where we resuscitate people, where we package them up and get them ready to go home. So let's, if my slides will let me go through that, talk a little bit about what excellence in that discharge hour might look like. So I think the first thing is really looking at the epidemiology, the medications we provide. So for about 2 decades now, we've known that our discharge meds coming out of the ICU are a mess, and they're a mess in ways that are not simply medication reconciliation, but instead are related to often the things we do. So in the United States, we give opioids. We give opioids to everybody in the ICU, and we know that that is a major driver of the opioid epidemic in the United States that has led to it being the #1 killer of prime-age men and women in my great country. That's awful. We know that about 3% of patients who leave the ICU with no previous mental health diagnosis will go out on an atypical antipsychotic. That's a really large rate of atypical antipsychotics at a population basis when you think about the 5 million Americans who are going out every year. We know our antibiotics issues, and the previous speaker nicely laid out that we are probably sending people out on way more antibiotics than we actually need to, and that a contemporary approach can help us restrict antibiotics. And I would say in the United States, particularly where we've had questions after COVID, the questions of what's the anticoagulation plan? In a world where we discover incidental clots or we're potentially using empiric anticoagulation, making sure there's a coherent strategy where we're sending people out with some form of anticoagulation afterwards. So not merely have we restarted their home medicines, but have we stopped all the things that we did in the ICU to get through the night? Next question is follow-up. I'm running a little ahead of time unexpectedly, so I'll stop and tell you one of my favorite stories. A colleague of mine runs a post-ICU clinic and saw one of my patients 5 days after discharge from the hospital and asked him how his follow-up was going. Patient said, "Doing great, doc. You know, they saw that thing in my kidney, and so I followed up with my 6-month CAT scan." And he said, "Great, and really important to make sure we follow up that incidentaloma. Speaking of your kidney, how is your urination going?" And he said, "Oh yeah, no, I've noticed that I don't really pee anymore since I go home." And he said, "Okay, so what does your nephrologist think?" He said, "You know, I haven't had time to make that appointment yet. I wanted to focus on the CAT scan to make sure I didn't get my tumor missed." And so I love our patients. They're wonderful. Their priorities are not always our priorities. And there's many a day where we're pushing people out of the ICU because we have 4 or 5, 6, 7 new patients coming in. We're saying the floor is going to set things up, and then the floor is saying that's fine, they can set them up when we go home. I think we know how complicated all of our healthcare systems are. We know how difficult it is to navigate them for even us as clinicians. And so I can only imagine what it's like for these families. So making sure our patients actually have the key follow-up and not just that list of 15 organ dysfunctions they might follow up with, but what are the ones we need them to get done and can we actually set that up for them? Next piece is in lines and tubes. I trained for a number of years at University of Michigan. University of Michigan puts in a lot of retrievable IVC filters. Love the retrievable IVC filter. University of Michigan also retrieves about 30% of the retrievable IVC filters that are put in there. We just don't go back and get these things out. There are stories of people who run post-ICU clinics, of people coming in with what they went out with, thinking it was a drain, and it turns out it was a femoral dialysis catheter. If we look at most of our, there are at least 2 hospitals that have done this, where they rounded with the hospitalist and said, "Does your patient have a line?" And fully a third of the patients who had central lines, the hospitalist caring for them didn't know. When we say that, it's really easy to blame the clinicians. And honestly, a little bit of clinician blaming is probably not unreasonable in those strategies, but we also know how busy our folks are, and we know how things are moving. So making sure there's actually a plan for everything we put in the patient to actually come out of them, and that they have a written recap so that when they go to see their primary care doctor, and their primary care doctor takes down their gown and says, "What's that scar from? What's that scar from? What's that scar from?" They actually know, and so they know which of those are risks and which of those are things that are just going to follow up. We send them out from a world where they've had 1-to-2, 1-to-1, 1-to-4 nursing to a world where they need to make it on their own. And that has 2 components. One is their house actually safe for them? Physical therapy and occupational therapy are an essential piece of this, and can they actually pay for what they need? Those of you who live, those of you in my audience here will have varying degrees to which your nation chooses to provide universal health care and chooses to provide that adequately. My nation does not choose to provide universal health care, and so often we'll send people out with plans for them to buy meds there's no way they can afford. It seems like that's a bad plan. And finally, really educating patients. A lot of folks are such in a rush to get out that last day. They want to get home. But do they actually know what the common readmission issues are? Do they know that they're in a potentially immunosuppressed state for the next 90 days? Do they know that the high risk of heart failure, if they start to gain weight, they should call because we can actually give you some Lasix and you can make that better? Is there a plan for exercise and for reconditioning? Right? Folks who go home often want to go home and think of the same advice their mom gave them. So when you're 12, if you get sick, it's okay to stay on the couch and wait until you're feeling all the way better before you exercise again. If you're 50, you gotta start walking before it feels better because it's never gonna feel all the way better because middle age is awful. And so these are the things, right? Do you have a plan for them to be a gradual, appropriate reintroduction of education, reintroduction of exercise? And finally, reminding them that depression, cognitive impairment are incredibly common for weeks to months afterwards. And so yes, it's gonna feel better to be home than it is in the hospital, but they're not gonna heal like they're football players who are 18 anymore. It's gonna take them a while to get back and making sure there's a plan for you manage their expectations. So look, we're all making this up together, trying to understand across our specific contexts, which vary incredible, hospital to hospital, as we go back and forth as to what the right way to do this is hard. There's my email address. I'm happy to share my slides if you find them useful. And if you're at the gala tonight, I'd welcome a chance to have a conversation. Thanks so much for your time.
Thank you very much. We have the time for one question. Can we give the mic to the back?
Well, thank you so much, Dr. Theodore, and also the previous panelist. I will pick on one word you said about the patient priorities or knowledge, and it's not a hot potato game, but our priorities based on our information. And I did work as a patient advocate related to critically ill during COVID for metastatic patients. And unfortunately, it was perceived as acceptable casualty in that time to have sepsis unchecked. Not intentionally though, because some of the side effects of the treatments for advanced cases can be 80% or 60% of the symptoms can be confused with sepsis. So the question is, this is a great forum, and in every field, we are doing a great job, but I fear that we are working silos. ICU, oncology, cancer, patient advocacy, where the responsibility, the more prevention we can achieve, the better it is for everyone. How to achieve prevention is the key question, so I will pick your brain on that. Thank you.
Oh, that's a big one. Right, because there are very few things that's frustrating when you spend a week, 2 weeks, doing everything and working someone back from the edge of mortality, and then 3 weeks later, you're back in the ICU covering for a colleague, and there they are back in the bed because some ball got dropped, right? And you spent 300 person hours, and 15 minutes of confusion led to not. There are lots of general answers, none of which have really worked well. So also in forums like this, it's traditional that we could spend about 3 hours playing the, is this primary care? Is this the oncology's? Who other than me's fault could this be? And yes, it could, there are lots of other people who might be better at it. I think the question is at your particular institution, who is the person who you can actually carve out the time for to help correct this? My general sense is it's a really hard problem. A lot of these people need a really good doc, and it doesn't entirely matter who that doc is, as long as there's someone who's willing to second guess the hospital discharge stuff to try to decide what of the hospital discharge was an intentional plan and what of it was inadvertent, and try to work through them. Please.
I'm saying, like, it's not only the doctor's responsibility, even caregivers, loved ones, everyone in the society, stakeholders, because it's not a secret that, at least for the cancer case, treatment-related immunosuppression, malignancy, comorbidities, they are not surprising. So I think, and there has to be something done to raise awareness about the possibility of sepsis for these weak or risk factor groups. How is the key question? Everyone is doing things in their own space, like as patient advocate, but there are still mortalities. And I listened to many of the professors here. Very thrilled to see you like real time in Kuwait for the first time. Professor Vincent, I listened to him 2 years ago with the Sepsis Alliance. So it's thrilling, but we really need to do something. And that's why I raised the voice about that. Thank you so much.
I completely agree. I think that is a fine last word, exactly as Dr. Fox-Robichard was talking this morning, right? We need policy to help support this. So thank you for raising your voice.
Thank you very much. Thank you. So it gives me a great pleasure to introduce our next speaker. I hope I'm pronouncing your first name correctly. Prof. Dijali Anani is a professor in medicine at University of Paris and University of Versailles. He is a director of general ICU at Raymond Boyncare Hospital. And it gives us a great pleasure to have you here today. And you're going to be presenting for us about the corticosteroids in use in septic shock patients.
Thank you very much for this very kind introduction. Needless to say that I'm deeply grateful to Abdurrahman and all his team for offering me the opportunity to contribute to the 20th Pan-Arab Critical Care Conference, which is also organized to the first Pan-Arab conference within the World Federation of Intensive and Critical Care Societies. So it's amazing to talk about a drug that is on the market now for a time that is as long as I am old. So here are my activities that may have influenced the selection and the interpretation of the data I'm going to show to you today. So let's take a walk, very short walk, from physiology to pharmacology, clinical evidence, and then perspectives about the use of corticosteroids in severe infections. So physiology, very briefly, in a normal healthy tissue, we all have resident cells that are sentinel, waiting for something wrong happening. And when happened a break to the epithelium, then these resident cells are the first to sense the threat. They detect the so-called pathogen-associated molecular patterns and the danger or damage-associated molecular patterns. You need to have both of them to activate these cells that then will trigger an immediate response. And it's important to understand that this response, of course, is promoting inflammation with different aspects, and in particular is releasing chemokines to get more cells coming from the blood. But in the same time, these resident cells are producing cortisol on sites to counteract, to fine-tune the response, to avoid too much of pro-inflammatory mediators to be released, and also within hours and days to fine-tune the amount of cells that are recruited from the blood. The idea is to have a balance in between fighting against the pathogen and avoiding damaging normal tissues. And again, these resident cells will produce continuously cortisol. So it's mainly cortisol released at the tissue level rather than cortisol produced by the adrenal gland that contribute to the initial response to the threat. Very importantly, these endogenous cortisol that is released continue to play a role in the late phase of inflammation at the time where it's needed to turn off the inflammation and to promote the repair of the epithelium and of a normal tissue to get back to the normal situation. So one can see how endogenous cortisol and thereby exogenous cortisol, corticosteroids, will intervene at almost all steps of the inflammatory response. So some words about pharmacology. As I mentioned, hydrocortisone was synthesized the first time 61 years ago at the Mayo Clinic and then commercialized by Merck, so in 63. And now we know pretty well how it works. We know the molecular mechanism of action of corticosteroids. So we know that corticosteroids first will interact with membrane sites of the cells and triggering very fast non-genomic effects. So the effects that are observed within minutes and hours from corticosteroids are mainly non-genomic effects that are related either to interaction with the membrane sites and or with the release of a chaperone proteins that are bind to the inactive glucocorticoid receptor in the cytosol. The second pathway of action of corticosteroids in the cell is, of course, binding to the glucocorticoid receptor. And then that complex become able to translocate to the nucleus, and in the nucleus will, by at least 3 different mechanisms, either block or interrupt the reading of genes. So that is the cis repression activation. By these mechanisms inhibiting the release of pro-inflammatory mediators. Or there is also transactivation of other genes, for example, genes coding for interleukin-10. So again, the mechanisms are very well known now. And when I was at the medical school, I was taught that corticosteroids suppress the function of immune cells. Well, we know now that was elegantly demonstrated by Stefan Bornstein in Germany a while ago now, where he took monocytes from patients and exposed them to dexamethasone and looked at the activation of genes. And as summarized on that slide, he found that there was many more genes that were upregulated, so with red colors in the immunofluorescence tools, than genes that were repressed or downregulated in the green color. So the cells are reprogrammed. They are not suppressed, and they are reprogrammed, as one can see, to promote innate immunity and to control adaptive immunity. What happened in vivo, if you took rabbits and you challenged rabbits with LPS in the lung, one can see here using immunofluorescence techniques that the green color highlights huge amount of NF-kappa B being released. And also one can see the blue circles is the nucleus. One can see NF-kappa B present in the nucleus with the nuclear translocation of that factor. Now, if you treat the rabbits with corticosteroids and sacrifice the rabbits after 10 days, one can see that corticosteroids completely blocked and suppressed the release of NF-kappa B, even NF-kappa B that had already translocated into the nucleus. So that was rabbits. Colleagues in Germany took monocytes from septic patients in the ICU and looked at NF-kappa B activation using Western blot techniques here before treatment by hydrocortisone, and the monocytes were ex vivo challenged by LPS. Monocytes were taken from patients with septic shock. And one can see on the Western blot that there was increase or overexpression of NF-kappa B by the monocyte of these patients. After 1 day of treatment with hydrocortisone, there was a substantial decrease in the amount of NF-kappa B that was expressed by these monocytes. And after 5 days, there was full inhibition of NF-kappa B released by these monocytes. So clearly, if one look at NF-kappa B activation as a treatable threat, corticosteroids are a powerful drug to counteract that NF-kappa B hyperactivation. So one can really be confident that the likelihood of benefit from corticosteroids when you have an NF-kappa B-driven inflammation is very high. So how do these translate at the bedside? Definitely, if the patient is not able to produce sufficiently endogenous corticosteroids, the patient, as we know in the classical Addison disease, the patient will be much less sensitive to alpha agonists like norepinephrine. If you give a single bolus of 50 milligrams of hydrocortisone, one can see that you restore completely in the patient the sensitivity to the alpha agonist. So what is the clinical evidence? So again, I'm biased in the selection of data, of course. So this is the work that the first French trial that was enrolling 300 patients randomized to receive the combination of hydrocortisone plus hydrocortisone versus placebos. And what was found in that study is that those patients who were non-responding to the synactin test had a substantial improvement in mortality, in reduction in mortality and improvement in survival. Corticus, the European trial that was published in 2008, as you know, was a negative trial. But with Charlie Sprung, where we looked at the patient in the Corticus study that met the entry criteria for the French study. Look at the graph. We reproduce exactly the finding of a French trial. So that is an important message, again, to be delivered. Well, now I think that the recent decade has provided major information from large randomized controlled trial. You have the approach trial comparing hydrocortisone plus hydrocortisone for adults with septic shock, published in 2018, reproducing the survival and mortality reduction with corticosteroids. We know that during the pandemic, corticosteroids were the first drug showing survival benefit in severe COVID-19 patients, in particular those who met criteria for sepsis or ARDS. And finally, also recently, the French multicenter randomized trial showing substantial survival benefit from hydrocortisone in patients with severe community-acquired pneumonia and without shock at baseline. So this busy forest plot is the 2025 update of the Cochrane review about corticosteroids in children and adults with severe infection. It's based on 87 RCTs. 87 RCTs. Only look at the black diamond in the bottom of the slide and look how far it is from the neutrality line. That is with 87 trials, more than 22,000 patients. So, of course, the p-value is 0.40. So it's highly significant. And there is really not much heterogeneity in the study, either by looking graphically at the distribution across the neutrality line of individual rows, but also by looking at the I-squared statistics. Anyway, not all may benefit from that treatment, and also we need to figure out the practical modality to treat the patients. So should we give boluses, or should we treat the patient with continuous infusion of hydrocortisone? Well, owing to the available data, there is no evidence of superiority of one modality about the other. So do what you do usually. If you used to use boluses, continue using boluses. If you're more confident with continuous infusion, continue to use continuous infusion. The current evidence do not support the superiority of one mode versus another. Should we stop abruptly, or it is of importance to taper off? No matter at all. So again, if you're used to stop abruptly, don't change your practice. If you used to taper off, don't change your practice. There is no evidence that one mode is superior to the other. What about now? Should we really give it to everyone, or should we try to focus on those more likely to benefit? It's a very difficult question to answer. So we arbitrarily define the uncomplicated sepsis as opposed to the other setting. So compared to that uncomplicated sepsis, in which group there is no evidence of benefit from corticosteroids, one can see that when shock is present, or sepsis is associated with ARDS, or sepsis is related to community-acquired pneumonia or to COVID-19, then the likelihood of benefit, of survival benefit from corticosteroids is substantial. And this is not related to baseline severity of illness. Looking at meta-regression with 87 trials, so I think it's a robust meta-regression, one can see that there is no evidence that the baseline severity that we did assess by the observed mortality in the control arm, one can see that this is not a modifier of the response to corticosteroids. What about dose of treatment and duration? Again, using meta-regression, we observe that there is a significant interaction between the dose and the response in terms of survival. The lower the dose, the better the survival, with the optimal dose being likely somewhere in between 150 and 300 milligrams of hydrocortisone or equivalent per day. And for the duration of treatment, it is likely that the optimal duration of treatment is somewhere in between 200 hours to 300 hours. So what about adding fluorocortisone, or should we use hydrocortisone alone? So fluorocortisone given orally is very well absorbed. We had this study 8 years ago, and we all know the most recent study by our colleagues from the ANZI group that investigated different doses of fludrocortisone in patients with septic shock and looked at the PK/PD of oral administration of fludrocortisone, highlighted that the dose of 50 microgram per day might be the optimal dose to be tested in a new in future trial, and also highlighted that indeed the oral administration of fludrocortisone is rather well absorbed and rapidly absorbed. So we conducted almost 10 years ago, 10 years ago, almost 15 years ago, in a 2x2 factorial design where we looked at tight glucose control in septic shock patients treated with corticosteroids, and also we looked at the value of adding fludrocortisone. So that study was not powered for answering the second question, but we observed a 3% absolute difference in mortality. This was hospital mortality in patients receiving the combination of hydrocortisone plus fludrocortisone. And interestingly, as you know, a large study based on data with emulated techniques conducted in the US also nicely suggested that the likelihood of having greater chance of survival with the combo rather than with the use of hydrocortisone alone may help in the decision in the clinical practice. There is heterogeneity to the response. We know from data that almost 4 out of 10 patients who died with sepsis or septic shock are actually immunosuppressed patients. They have the so-called immune paralysis. And also we know that 3 out of 10 patients are resistant to corticosteroids. So we need to try to figure out a way to find these patients with sepsis or severe infection that actually have hyperinflammation, not immune paralysis, and don't have resistance to glucocorticoid. And this is the challenge for the future. So there are numerous teams looking at the use of machine learning and deep learning. Here with Romain Piracchio in San Francisco, we built an intelligent algorithm that, as shown here, was able to really discriminate those patients who might draw survival benefit from corticosteroids. And we are now testing that intelligent algorithm in a large multi-center randomized controlled trial. We also figure out that frequent variants that are present in between 20 to 40% of patients with severe infection. These variants are polymorphism in the promoter region of a gene of NF-kappa B, and also in the promoter region of another gene that is implicated in glucocorticoid receptor regulation, GLCCL1. We found that the patients who bear the 2 variants had a huge benefit in terms of survival from corticosteroids. So, and we are also testing now in a basket trial to confirm that this genotyping, that is very easy to do at the bedside by PCR technique, may allow identifying patients with major survival benefit from corticosteroids. So what to do for practice, waiting for these ongoing studies and experiments? What we are doing, I'm not telling what you should do, I'm just telling what we are doing in our unit. So we'll continue using hydrocortisone as a bolus of 50 milligrams, giving Q6. We systematically add fludrocortisone, 1 tablet of 50 mics once a day. We treat the patient for 7 days. unless the patient is discharged the hospital before, and we never taper off. And we do not treat everyone. We treat patients with septic shock, and we do not wait 48 hours after the patient is on norepinephrine. If a patient is not weaned from norepinephrine in the first 6 hours, we start immediately hydrocortisone and hydrocortisone. In these patients, we treat patients with sepsis that meet criteria for ARDS. We treat patients with severe community-acquired pneumonia, and of course, because we continue to have some patients severely affected by SARS-CoV-2, we also treat them with COVID-19. And yeah, we also continue doing the synactin test. I will discuss this the day after tomorrow. And this allows us to subphenotype our patient and to decide not to prolong corticosteroids in patients who are responding to the synactin test. Thank you so much for your attention and patience.
Thank you very much, Prof. Anani. We will have one question, if anyone has anyone.
That is, so the question was about what about giving corticosteroids in severe H1N1 infection? So as you know, that this is a major controversy. I think we should learn from lessons from the COVID-19 pandemic. Don't forget that at the very beginning, the WHO recommendation was against the use of corticosteroids in severe COVID-19 patients. That was based on flawed previous work. There is no single randomized controlled trial that have addressed the effects of corticosteroids in severe flu. There are actually 3 ongoing trials, large. So the REMAP-CAP platform has is investigated corticosteroids in severe flu. The recovery platform is also investigated, and the large French study is also investigating. The large French study is a double-blind, placebo-controlled study, whether the platform, of course, are open-labeled for obvious reasons. So hopefully in a couple of years, and don't worry, as you know, flu comes every year, so we will, but in a couple of years, we may know if we should use them or not.
Go ahead.
I guess you chose the hydrocort. Any difference with DEXA or other forms of steroid?
Yeah, there's major differences in between dexamethasone and hydrocortisone. For example, dexamethasone has absolutely no non-genomic effects. So dexamethasone is a powerful, has a powerful glucocorticoid activity, so it's powerful to block NF-kappa B, but has no effect on the MAP kinase pathway, for example. So you don't have rapid effect with dexamethasone. This is why you cannot use dexamethasone in anaphylactic shock, because it's going to take hours to work, okay? In contrast to hydrocortisone or methylprednisolone. Yeah, you know, in the community-acquired pneumonia, in ARDS, I think it's not a matter of minutes or hours. You have a couple of days, and in this setting, dexamethasone, I think, work as well. In septic shock, it might be different, because in septic shock, minutes and hours matters. You have to act more rapidly. So in septic shock patients, my inclination is to prefer using hydrocortisone. Thank you.
Thank you very much. Thank you everyone for staying late. I really appreciate your energy. Thank you, and have a good evening.